Hi, welcome to our channel of IGNOU audiobooks. Indira Gandhi National Open University, School of Continuing Education, Certificate Programs, Certificate in Nutrition and Child Care, CNCC, CNCC-1 Nutrition for the Community. BLOCK-5, Nutrition-Related Disorders, Unit-17, Major Deficiency Diseases I, Protein Energy Malnutrition and Xerophthalmia. 17.1 Introduction. This unit will deal with two of the major deficiency diseases, namely protein energy malnutrition, PEM, and xerophthalmia, vitamin A deficiency. You learnt earlier that the human body requires energy to carry out the different activities and proteins are necessary for growth and repair. In this unit we shall learn as to what happens when there is deficiency of energy and protein in the diet. The deficiency of these two basic nutrients in our body leads to protein energy malnutrition. Similarly, due to lack of vitamin A-rich foods in the diet, vitamin A deficiency or xerophthalmia results. These two deficiency disorders have very serious consequences and are major nutritional problems in India. Which section of the population group is more vulnerable to these diseases? What are the major features, causes, and clinical features of these two widespread disorders? How can we prevent them? What treatment can be prescribed? These are some of the issues which are discussed in this unit. Objectives. After studying this unit, you will be able to describe the nature and causes of PEM and xerophthalmia. Enumerate the clinical features of PEM and xerophthalmia and discuss the treatment and prevention of these disorders. 17.2 Protein Energy Malnutrition. Protein energy malnutrition, PEM, is widely prevalent among young children, 0 to 6 years, but is also observed as starvation in adolescents and adults, mostly lactating women, especially during periods of famine or other emergencies. PEM has serious consequences for the health of individuals, particularly children, and can even result in death. Let us first define PEM. PEM can be defined as a range of pathological conditions arising from a deficiency of protein and energy and is commonly associated with infections. What kind of adverse changes take place in the body as a result of PEM? The adverse changes which are externally noticeable are referred to as clinical features, which we will read as we go through this section. In Unit the first of Block 1, you may recall reading about signs of good health related to different body parts like the eyes, the skin, the teeth, etc. Many diseases result in adverse changes in the appearance and functions of one or more body parts. For example, a healthy person has clear eyes. But in a person with severe vitamin A deficiency, eyes lose their clarity and become muddy or cloudy. Similarly, a child suffering from PEM is shorter than other children of the same age. Such changes in appearance relating to the body as a whole or its parts are referred to as clinical features of a disease. The clinical features can be easily detected by trained individuals. Let us now study the clinical features of PEM. Clinical features of PEM. PEM is a condition characterized chiefly by the following two forms: A. Marasmus, B. Kwashiorkor. Marasmus is a condition characterized by very low body weight for age, loss of subcutaneous fat, fat under the skin, gross muscle wasting. It is observed more frequently in infants and very young children. Kwashiorkor, on the other hand, is a condition characterized by edema, excessive accumulation of fluid in the intercellular spaces of tissue, and very low body weight for age. The syndrome is most frequently observed in children aged 1 to 3 years and is precipitated by an infection or more commonly by a series of infections. However, there are also children who show some of the characteristic signs of both marasmus and kwashiorkor. Such children are said to suffer from marasmus kwashiorkor. Then there are children whose heights and weights are considerably below that of healthy children of the same age. These children may not show any typical clinical signs of either kwashiorkor or marasmus, and as such, they are placed in the category of subclinical forms of PEM, which forms a large proportion of the disease in the community. The subclinical condition means that we do not see the clinical features of the disease. These forms of the disease can be identified only through special investigations or tests. In the case of PEM, we can detect subclinical status by measuring body weight. In all the forms of PEM, remember, growth failure or low body weight is a common sign. So then, how are these forms different from each other? The description below presents a clear picture of the different forms of PEM and lists signs and symptoms specific to each form, which will help us identify individuals suffering from different forms of PEM. We begin our study by identifying signs and symptoms of marasmus. A. How to identify a child suffering from marasmus. Some common clinical features of marasmus include I. Muscle wasting. The characteristic sign of marasmus is the extensive wasting of muscle with little or no fat under the skin. We use the term wasting to mean emaciation or thinness of the body. The ribs become very prominent. Because of the absence of fat, the skin will develop a number of folds, particularly on the buttocks. The child with marasmus, thus, can be described as skin and bones. You can see this clearly in figure 17.1. 2. Failure to thrive. There is failure to thrive, and the child suffering from marasmus usually is irritable and fretful. In fact, the child is often so weak that the cry of the child cannot even be heard. 3. Growth failure. Failure to grow is another important feature of the disease. The children often weigh about 50% less than normal children for their age. For example, a healthy normal 1-year-old child weighs about 10 kilograms. Whereas, a marasmic child would weigh only about 5 to 6 kilograms. In addition to these clinical features, there is usually watery diarrhea associated often with dehydration, loss of fluids. The child may also have other deficiencies, particularly vitamin A deficiency, details of which are given in section 17.3 of this unit. Look at the screen for table content. Figure 17.1 Child with marasmus. Photo courtesy, National Institute of Nutrition, Hyderabad. B. How to identify a child suffering from kwashiorkor. Some common clinical features of kwashiorkor include I. Edema. Edema is the excessive accumulation of fluid in the intercellular spaces of the tissues. Edema is usually observed on the lower limbs, but it may also be distributed all over the body, including the face. Remember, kwashiorkor should not be diagnosed without the presence of edema. But how can we detect edema? We can detect edema by pressing the skin over the shin of the leg with our fingers. Because of the accumulation of fluid under the skin, when you press, there will be a depression at the place where the pressure is applied. 2. Failure of growth. Growth failure is an early sign, and we can notice this by taking body weight. Children with kwashiorkor weigh only about 60% of the weight of normal children for their age. For example, a 3-year-old healthy normal boy weighs about 13.5 kilograms, whereas another boy of the same age but suffering from kwashiorkor may only weigh 60% of 13.5 kilograms, about 8 kilograms. In other words, they are very much lighter than healthy normal children of their age. 3. Irritability. The child suffering from kwashiorkor is generally irritable and has no interest in his/her surroundings. 4. Skin changes. In addition to the above manifestations, there may be characteristic skin changes. The skin becomes thick and appears as though it has been varnished. The skin of the child may peel off easily, leaving behind cracks or sores. V. Hair changes. The hair may become sparse and can be easily pulled off. The hair usually loses its black color and appears reddish-brown. Y. Moon face. The face of the child suffering from kwashiorkor may appear puffy with the cheeks sagging. This sign is normally known as moon face. Figure 17.2 shows some of the clinical features like edema, moon face, and skin changes clearly. Look at the screen for table content. Figure 17.2 Child with kwashiorkor. Photo courtesy National Institute of Nutrition, Hyderabad. 7. Associated deficiencies. The children may have signs of other deficiencies like those of vitamin A and B complex deficiencies. What are these signs and symptoms? You will learn about these deficiencies in the subsequent units of this block. 8. Associated diseases. The child is often brought to the hospital with watery diarrhea, frequent loose motions, or severe respiratory infection, cough. The children often will be recovering from measles, a childhood disease, which is characterized by skin rash and fever. Our study of the clinical features of kwashiorkor and marasmus revealed that growth failure is characteristic of both these conditions. However, it is much more pronounced in marasmus. Can you now identify exactly is the difference between these two conditions? Make a checklist and tally your responses with the principal features of PEM given in Table 17.1. Table 17.1, Principal Features of PEM. Look at the screen for table content. C. How to identify marasmic kwashiorkor in children. In India, particularly among poorer families, we also come across patients who present a mixture of both kwashiorkor and marasmus. You have earlier learned that these are referred to as marasmic kwashiorkor. The children are not only extremely wasted like in marasmus but also have signs of kwashiorkor, i.e. swelling of feet, edema. D. How to identify subclinical forms of kwashiorkor. Subclinical forms of a disease, as you know, refer to the condition where external medical examination may not show any signs of the disease. However, when we examine in detail by body measurements like weight or examination of blood, we can detect changes. In the case of PEM, we can see a large number of subclinical forms. Kwashiorkor and marasmus are actually considered as the tip of an iceberg. In our country, only 2 to 3 children out of 100, in the age group of 1 to 5 years, exhibit these clinical forms of PEM. However, many more subclinical cases of PEM which cannot be easily detected by simple clinical examination are widely prevalent in the community. 4. Each case of kwashiorkor or marasmus, there may usually be 10 to 15 subclinical cases of PEM. For prevention of PEM, we have to take steps by identifying such cases so that prompt treatment or rehabilitation, help child to recover his normal health, can be provided. How do we diagnose these? We have already learned that children with kwashiorkor or marasmus have very low body weights. Similarly, by taking body weights we can also identify subclinical forms of PEM. A child's body weight is compared with that of a well-fed, healthy normal child of the same age. The weights of normal children used for such a comparison are known as reference standards. These tables of normal weights and heights of healthy normal children provide weights and heights according to age. In India and elsewhere, the reference standards developed by the National Center for Health Statistics, NCHS, of the USA are extensively used. The reason is that the growth pattern of well-to-do Indian children, at least until adolescence, is comparable with that of American children. Table 17.2 gives the weights of healthy American children which are recommended to be used as standards. Table 17.2, Average weights of healthy American children, NCHS. Look at the screen for table content. By comparing the weights of children with those of healthy normal we can classify the children into different forms of malnutrition. The Indian Academy of Pediatrics, LAP, recommended the following classification, Table 17.3, for detecting different forms of PEM using weight for age. Table 17.3 Simple classification of PEM. Look at the screen for table content. For example, let us consider a child of 1 year age. A normal healthy male child of this age should have a weight of 10.2 kilograms as indicated in Table 17.2. You know that children weighing more than 80% of healthy children are considered as normal as per the LAP classification. 80% of 10.2 kilograms is 8.16 kilograms or 8.2 kilograms. So a child weighing more than 8.2 kilograms is a normal child. Similarly, you can calculate 70% of the weight of 5-year-old children. In this case it is equivalent to 7.14 or 7.1 kilograms. So, children with weights between 7.1 and 8.2 kilograms are considered as suffering from mild malnutrition. You can calculate the other grades in a similar way. You may be wondering what is the use of such a classification. Information given in highlight. I will draw your attention to this crucial aspect. You are listening to this audiobook on Audio Learn IGNOU. Highlight 1. Supplementary feeding programs. Malnutrition is the major problem facing the country. Children suffering from malnutrition need special attention. Those in moderate and mild degrees of malnutrition require additional food in order to bring their weight to normal, whereas those children suffering from a severe degree of malnutrition need special attention by a health functionary as they usually suffer from diarrhea, respiratory infections and other diseases. The crucial aspect, however, is how we detect these cases of malnutrition. We can make use of the classification given in Table 17.3 to identify cases of malnutrition. Based on this information, we can then select children to participate in feeding programs. Generally, those children with moderate and severe malnutrition, based on weight for age, are included in the supplementary feeding programs. What are these supplementary feeding programs? Supplementary feeding programs are simple nutrition intervention programs initiated by the government to help meet the nutrient needs of the vulnerable sections of the society, especially children and pregnant/lactating women. You will read about them in Unit 24 of Block 6. The main objectives of the feeding programs are to supplement the diets of the weaker sections of the community to combat undernutrition and to educate the community for combating and preventing malnutrition. From our discussion so far, we have got an idea of how to identify the different forms of PEM. The next question which comes to our mind is, what are the causes of this widespread disorder? The discussion which follows presents a detailed review of some of the causes of PEM. Check your progress exercise 1. 1. What are the differences in the clinical features of kwashiorkor and marasmus? 2. Fill in the blanks. A male child of 1 year weighs 4.7 kilograms as against a normal of 9.5 kilograms. The child is suffering from blank form of PEM. B. A child who has extensive wasting of muscle is suffering from blank. C. In the case of PEM, subclinical forms can be identified by using blank. D. Blank is the condition characterized by sagging cheeks and puffy face. E. Blank is the condition where external medical examination may not show any sign of the disease. What are the causative factors of PEM? Some of the causes of PEM are: A. Poverty. PEM occurs in poor Indian communities. It is commonly seen in families of landless agricultural laborers and tribal communities without any regular earnings, among others. In India, PEM is seen in backward communities of Harijanas, nomadic tribes and children in urban slums. These communities are poor, illiterate, generally don't have large families. B. Maternal malnutrition. Do you recall the discussion we had in Unit 8 of Block 3 on nutritional status of the mother and its impact on pregnancy? We learned that the nutritional status of the mother determines the state of nutrition of the child to be born. If the nutritional status of the mother is poor, the chances of the offspring being malnourished are higher. Maternal malnutrition results in low birth weight of offspring. A poor Indian infant starts life with a handicap. The weight at birth of such an Indian child is lower than the normal children. You are aware that a normal infant is about 3 kilograms at birth. Infants with birth weight more than 2,500 grams, 2.5 kg, are considered as low birth weight babies. In rural areas, villages, Among poorer groups, for every 100 children, about 30 to 35 have low birth weight. In well-fed, normal and healthy children, this is noticed only in less than 10 out of 100 children. Children who develop PEM often begin life with a low birth weight. You will find a detailed discussion on maternal malnutrition in Unit 22. C. Infections and poor hygiene. Generally, kwashiorkor or follows attacks of diarrhea, frequent loose motions, or an attack of measles. You will learn the reasons for this 11/Unit 20 of this block. In the urban slum areas, artificial feeding with commercial milk foods is common. The mothers may follow unsound and unhygienic methods of feeding the child. Feeding bottles may not be properly sterilized. Flies may be allowed to sit on the nipple of the feeding bottle. This may lead to frequent diarrhea and lead to marasmus. D. Ignorance. Both the forms of PEM occur as a result of ignorance of the mother, in addition to poverty. The mother, due to ignorance, delays the introduction of supplementary food, in addition to breast milk, even up to the age of a year. This has serious consequences because the mother's milk alone is not enough for the child by the age of 6 months. The infant should be given supplementary foods in addition to breast milk. In addition, mothers restrict the diet when the child is suffering from infections such as diarrhea, measles and common fevers. This practice is not good since such a dietary restriction leads to PEM in children who are underfed. E. Wrong child feeding practices. You have learned that supplementary foods in addition to breast milk are introduced quite late. The child is usually given the same diet taken by adults. The typical Indian diet is based on cereals and is quite bulky for a small child. This would mean that the child can consume only smaller amounts of the food at one time. But you remember reading in Unit 9 of Block 3 that the child should be given frequent meals at least 5 to 6 times a day to meet the daily requirement of nutrients. However, traditionally an Indian child is fed thrice a day. As a result, the child does not get adequate food. Consequently, the child cannot get enough energy, protein, which is the major cause of PEM in India. It may be mentioned here that the protein intake is, however, just a little less than what is required. It is the intake of energy which is largely deficit. What is the treatment for PEM? Now that you are aware of the causative factors of PEM, let us move on to discuss the prevention and treatment of this disorder. You know, PEM is caused due to deficiency of energy and protein in the diet, or in other words, due to lack of food. So one of the major objectives of the treatment is to feed the child energy and protein-rich foods so that his requirements are met and there is adequate weight gain. This treatment can be very well done at home with judicious selection of energy and protein-rich foods. However, the children with severe malnutrition most often require hospitalization since they may also have associated infections like severe gastroenteritis, infection of the digestive tract, and severe respiratory infections. If you come across such a case, ask the mother to take the child to a health center where treatment for these infections is given first priority. In the initial stages, it will be difficult to feed such children. They may require feeding through a rubber tube passed through the nose into the stomach till they are able to take the food by mouth. Initially, only high-calorie liquid foods are given. We can also treat some of these cases at the homes of the children with proper supervision, if they do not have any severe infections like diarrhea, etc. The main principle in the treatment of the severe forms of PEM is to provide adequate energy and protein through dietary means. This can be provided through the foodstuffs usually consumed by the community at their homes like cereals, pulses, nuts and sugar/jaggery. Addition of milk is not compulsory but, if added, will improve the quality of the diet. Remember that there is no need to give high-protein commercial preparations. A nutritious preparation used in the treatment of PEM is discussed in Highlight 2. Highlight 2 Hyderabad Mix. A preparation based on local foods which was developed by the National Institute of Nutrition, Hyderabad and successfully used in the treatment of kwashiorkor or marasmus is the Hyderabad mix. This Hyderabad mix, which is not a commercial food, can be prepared even in rural households belonging to poorer families. It consists of roasted wheat, 40 grams, roasted Bengal gram dal, 15 grams, roasted groundnut, 10 grams, and sugar/jaggery, 30 grams. We can prepare laddus or sweet kheer with this mix, or it can be cooked with milk to improve the taste and quality. In about 4 to 6 weeks, the children with kwashiorkor recover fully with dietary treatment, though cases of marasmus take longer periods. It is important to remember that during the first week the child requires persuasive efforts and coaxing for feeding. After this, once the child recovers their appetite, feeding becomes much easier. In young children of 6 to 24 months, who also have a problem in swallowing solid food, one can make a thin gruel of the Hyderabad mix by adding a few grams, white 2 teaspoons, of ARF powder, germinated wheat flour powder. You have already learnt how to make the ARF powder in Unit 9 of Block 3. The addition of ARF to the gruel would help make it thin but at the same time retain its nutritive value. The child with PEM can easily drink this up. Simultaneously, other deficiencies like those of vitamin A and B complex should also be treated with vitamin A capsules and tablets of B complex. In addition, associated infections should be controlled with appropriate antibiotics. The mother should be educated to continue feeding of additional food by increasing the quantities of the home diet even after discharge from the hospital so that the child may not get PEM once again. Mild and moderate cases of PEM can be treated at home by giving energy and protein-rich diets as mentioned earlier. They do not require hospitalization. How to prevent PEM? You know that prevention is better than cure. Few measures, which when followed will prevent PEM, are listed in the following discussion. Prevention of PEM should start with the mother of the child. You have learnt that children with low birth weights often develop PEM. As you have already learnt, the main reason for low birth weight is maternal malnutrition, i.e., the mother of the child consumes inadequate quantities of energy and protein during her pregnancy. We have to, therefore, ensure that a pregnant woman consumes extra food to meet the additional needs of pregnancy. A simple thumb rule is to ensure that pregnant women consume additional amounts of foods equal to one normal meal every day during pregnancy. In the case of poorer families, supplementary food in addition to home diet, can be given to the pregnant women during the last 3 months of pregnancy under government's feeding programs. These steps would help in improving the birth weights of the children. 2. Mother's milk is the best food for an infant. Lactating mothers should be encouraged to breastfeed their children as long as possible. By the age of about 6 months, however, mother's milk alone is not adequate for the child. Supplementary food should be provided to the children by the age of 6 months, in addition to breast milk. These can be cereal pulse and nut mixes, for g. wheat, Bengal gram and groundnut mix, and can be prepared at home by the mother. You could refer to Annexures 3 and 4 of Block 3 for more ideas on supplementary foods for infants and Annexure 5 for nutritious snacks for preschoolers. 3. Children should be fed 5 to 6 times a day. We have already learned that cereal-based Indian diets are quite bulky, and unless the child is fed frequently it cannot meet the energy and protein requirements. 4. Infections like diarrhea and respiratory infections increase the risk of PEM. Prompt treatment of these infections would, therefore, help to prevent PEM. In addition, during diarrhea and any other infection, food should not be restricted. The child should be fed as usual. Protection of children against diseases like tuberculosis or measles, whooping cough by immunization is another important aspect in the prevention of PEM. Under the Universal Immunization Program, all the infants receive immunization against all these diseases, which are important contributory factors in child malnutrition. Mothers should be educated to avail of these services. Check your progress exercise. 2. List any 3 measures which you would like to adopt to prevent PEM in a village community. 2. List the main causes of PEM in infants. 17.3. Xerophthalmia. Xerophthalmia refers to the eye manifestations, signs, arising due to vitamin A deficiency. Blindness, resulting as a result of xerophthalmia, is an important public health problem in India. It is estimated that about a quarter of the 15 million blind persons in the country are due to xerophthalmia. Although vitamin A deficiency may become apparent at all ages, the preschool child, in the 3rd or 4th year of life, is the most frequent victim of this debilitating disorder. What are the signs and symptoms of this disorder? On reading through the subsequent section, you will be introduced to the various eye changes, clinical features, common to vitamin A deficiency, clinical features of xerophthalmia. The clinical manifestations in xerophthalmia pertain to changes in the eye. Do you recall the figure of the eye given in Unit 4 of Block 2? The figure represented the structure of an eye. Once again, for your convenience, this figure is given here. In this figure you can see the various parts of the eye. It is the conjunctiva and the cornea, the 2 parts of the eye which are most often affected by the deficiency. Let us now look at the clinical manifestations of xerophthalmia. A. Night blindness. One of the earliest manifestations of xerophthalmia is night blindness. Individuals suffering from night blindness cannot see in dim light or at heady dusk. The child will be unable to see even the meal plate kept in front of her in dim light. This condition is known by different names in different regions. For example, in the rural areas of the North Hindi belt, this condition is commonly known as rathaundi. B. Conjunctival xerosis. Xerosis in Greek means dryness. Conjunctival xerosis, therefore, means dryness of the conjunctiva, thin transparent membrane that covers the cornea and lines the inside of the eyelid. In the normal eyes, the membrane covering the white portion of the eye, I.E. conjunctiva, bright white and moist. In the case of xerophthalmia, it becomes discolored, muddy-colored, dry and loses its brightness. This is known as conjunctival xerosis. Even when there are tears in the eyes, the conjunctiva cannot be wetted. C. Bitote spots. In addition to xerosis, dry foamy triangular spots may appear on the conjunctiva. These are known as Bitote spots, figure 17.3. Usually these are more common on the temporal side, towards the ear of the eye rather than the nasal, towards the nose side. In our country there is a practice among girls to apply kajal, eye-tex kohl, to their eyes. In such cases, bitote spots also take up the black color of the kajal and can be seen even from a distance. Though conjunctival changes in xerophthalmia do not lead to blindness, they should be considered as warning signs. If neglected, the changes may progress, affecting the cornea and may lead to irreversible blindness. D. Corneal xerosis. As in the case of the conjunctiva, the normal cornea, the anterior, transparent portion of the outermost layer of the eye, is moist and shining. When vitamin A deficiency becomes severe, the cornea becomes dry and dull and appears like ground glass. This condition is called corneal xerosis, which means dryness of the cornea. This condition should be treated as an emergency. If it is not treated immediately with vitamin A, the child can develop ulcers, sores, in the cornea. Cornea ulcers, corneal sores, when healed, leave white scars known as glaucoma. Such white scars on the back of the eye can interfere with normal vision. Figure 17.3. Child with bitote spots. Photo courtesy National Institute of Nutrition, Hyderabad. Look at the screen for table content. E. Keratomalacia. The most dangerous form of xerophthalmia is known as keratomalacia. In this condition, the cornea becomes very soft and raw and easily infected. It leads to the destruction of the eye. In other words, the eye gets completely melted and destroyed. Figure 17.4. This condition inevitably leads to irreversible blindness. Generally, this condition is seen in both the eyes and is common in children between the ages of 0.15 years. 60 to 65% of these children die. In addition, the prevalence of infections is also high in these children. About 95 to 96% of the children with keratomalacia also have either kwashiorkor or marasmus. Figure 17.4. A child who became blind due to keratomalacia. Photo courtesy, National Institute of Nutrition, Hyderabad. Look at the screen for table content. The study of this section would have given you an idea of how to identify clinical manifestations of vitamin A deficiency. But what is equally important for us is to know what are the causative factors of this disorder. Let us now learn about them. What are the causative factors of xerophthalmia? Xerophthalmia is common in families of low socioeconomic groups living in rural areas and urban slums. In India, the disease is more common among the poorer sections of the community. Vitamin A deficiency may become apparent at all ages. The most common, predominantly nutritional, variety occurs in the 3rd and 4th years of life, at least in countries where breastfeeding is prolonged. The younger the child, the more serious the manifestations and the greater the mortality rate. The cornea is rarely affected in children beyond the age of 5 years. In fact, the prevalence of corneal xerophthalmia is maximum between the ages of 1 and 3 years. The disease is relatively more frequent among males. The causes being A. Dietary inadequacy of vitamin A. The primary cause of xerophthalmia is dietary inadequacy of vitamin A. In the villages and urban slums, among the low-income groups, the intake of vitamin A is less than a quarter of the recommended dietary intake, RDI. Do you recall the RDI for vitamin A for different ages? For your reference, the RDAs for different ages are given below. Table 17.4, Vitamin A requirement. Look at the screen for table content. A. Maternal malnutrition. Indian children of very poor rural families are born with low liver stores of vitamin A because their mothers are also deficient in vitamin A. You have already learned that vitamin A is fat-soluble and can be stored for a longer period in the liver. Women during pregnancy consume very low amounts of vitamin A either due to poverty or ignorance. As a result, the children born to such women have low vitamin A reserves in the body. As long as the child is breastfed, the vitamin A status of the infant is apparently adequate because the infant gets reasonable amounts of vitamin A through breast milk. Once the child is taken off the breast, the child is put on the family diet which is deficient in vitamin A due to inadequate consumption of vitamin A. The child develops vitamin A deficiency manifesting as xerophthalmia. B. Infections and infestations. Diarrhea and respiratory infections and worm infestations like roundworm disease are very common in children. These are known to decrease the absorption of vitamin A and lead to deficiency. Measles, one of the childhood infections, is another important cause of xerophthalmia, leading particularly to corneal sores and blindness. Few of the most common causes of xerophthalmia have been discussed above. What preventive measures and treatment can be prescribed to overcome this disorder is the next point of discussion. What is the treatment for vitamin A deficiency? For the purpose of treatment, we have to first distinguish between milder forms and severe forms of vitamin A deficiency. You have already learned that the involvement of the cornea should be considered the most severe form since it can lead to blindness. These should be treated without any delay. Such cases need vitamin A injections into the muscle, intramuscularly, at the dose of 1 lakh IU. On the next day 2 lakh 4 of vitamin A is given by mouth. About 3 international units, IU, of vitamin A is equivalent to 1 microgram, UG, of vitamin A. Children with night blindness, conjunctival xerosis and bitoot spots are treated with a massive oral, by mouth, dose of 2 lakh IU of vitamin A. How to prevent vitamin A deficiency? Few measures to prevent vitamin A deficiency are listed below. I. Consume vitamin-rich diet. We know that xerophthalmia is primarily due to dietary inadequacy of vitamin A. Therefore, the most rational method of prevention of vitamin A deficiency is to make sure that communities consume foods rich in vitamin A regularly. Inexpensive foods like green leafy vegetables, palak, amaranth, etc., yellow vegetables, yellow pumpkin and carrots, and fruits, papaya and mango, are good sources of beta-carotene which, as you know, is the precursor of vitamin A. Consumption of as little as 40 grams of green leafy vegetables daily is enough to maintain the normal vitamin A status in children. However, improvement of Indian diets requires extensive and continuous nutrition education programs. 2. Periodic administration of vitamin A. Blindness due to xerophthalmia is a serious problem and requires the most urgent measures. We have already learned that vitamin A can be stored in the liver for prolonged periods and will be available to the body. It is possible to build up sufficient vitamin A stores in a child by giving large doses of vitamin A periodically. Using this principle, a national program for the prevention of blindness due to xerophthalmia has been developed by the National Institute of Nutrition, NIN, and is operated by the Government of India in the different states of the country. Under the program, children between the ages of 1 and 5 years are given a massive oral dose of vitamin A, 2 lakh IU, once every 6 months. The distribution of vitamin A is carried out by the village-level health workers like multi-purpose health workers of the state governments. Such CL program, when properly carried out, can bring down blindness due to xerophthalmia in 80% of young children. Simultaneous nutrition education is also important for the success of the program. You will learn more about this program in Unit 23 of Block-6. You are listening to this audiobook on Audio Learn IGNOU. Check your progress exercise. 3. 1. Fill in the blanks. A. Xerophthalmia is due to the deficiency of blank in the diet. B. Conjunctival xerosis means blank of conjunctiva. C. The most dangerous consequence of xerophthalmia is irreversible blank. D. Dry, foamy, triangular spots appearing on the conjunctiva are called blank. 2. The clinical features of xerophthalmia relating to the cornea are. 3. List the main causes of xerophthalmia in India. 4. What advice will you give to a mote of a preschool child in a village to prevent xerophthalmia? 17.4. Let us sum up. In this unit we studied about the two major nutritional deficiency disorders PEM and xerophthalmia. PEM is very common in our country and kwashiorkor and marasmus are the severe forms. Edema is present only in kwashiorkor and there is extreme muscular wasting in marasmus. PEM is due to dietary deficiency of energy and protein. Maternal ignorance, childhood infections, and low birth weight are the contributory causes. These can be treated by foods prepared from cereal, pulse, nuts, jaggery or sugar and other such energy, protein-rich foods. Improvement of the nutritional status of pregnant women, breastfeeding the baby, supplementation at about 6 months of age, immunization and prompt treatment of minor diseases like respiratory infections and diarrhea can help in the prevention of PEM. Xerophthalmia is due to vitamin A deficiency. It leads to irreversible blindness, particularly in young children. The clinical manifestations are seen in the eyes. These are night blindness, conjunctival xerosis, bitote spots, corneal xerosis, corneal ulcer and keratomalacia/dietary inadequacy. Infections, infestations and ignorance on the part of mothers are the contributory factors for vitamins A deficiency. It can be easily prevented by the consumption of inexpensive vitamin A-rich foods like green leafy vegetables, carrot, yellow pumpkin, papaya and mango. Blindness due to xerophthalmia can be prevented by the administration of a massive dose of vitamin A, i.e. 2 lakh IU of vitamin A, every 6 months to children between 1 and 5 years of age. 17.5. Glossary. International standards for weight, Body weights of normal and well-fed children, usually obtained from American children, used as the ideal standard for comparison. Intramuscular injection of medicines into the muscle for treatment of diseases. Malnutrition, condition occurring due to deficient or excessive intake of nutrients. Microgram UG, 1/1000th of a milligram. Precursor, it refers to any substance which can be converted to a vitamin in the body. For example, carotene is the precursor of vitamin A. Subclinical, disease condition which occurs before clinical signs/symptoms of disease occur. Thank you. We will see you in the next video.